Bob was born on November 20th, 2014, with no abnormalities and a normal weight of 7 pounds. Bob was doing really well for the first couple of days, but a week later, his mother noticed that he wasn't eating, he was respiring really quickly, he had irregular sleep patterns, random spasms, a sugary scented urine, and his mother also suspected acidosis. Bob's worsening symptoms and continuous crying made his mom worry, and so Bob was rushed to the hospital on account of these symptoms. He was hospitalized quickly, and his situation continued to deteriorate until he had to be fed through tubes. Bob was taken to see Dr. X, a well-known pediatrician at McMaster Children's Hospital. He was known for being thorough in his testing and accurate in diagnostics. And so, he first decided to perform a physical examination on Bob. He observed a normal skin color, a normal head size and shape, medium-sized pupils that reacted to light. However, he also noticed rapid breathing followed periods of apnea. Dr. X then sent some samples to the lab for further testing. The urine sample was normal in color, with a pH of 6 and indicated no albumin, sugar, or bile. He also sent bacterial cultures that yielded no pathogens. Finally, there was an unusual scent in the urine. This led Dr. X to suspect a certain diagnosis: maple syrup urine disease. To further confirm his suspicions, he ran some blood tests. The results came back showing that there were increased levels of isoleucine, leucine, and valine, the branched-chain amino acids, along with a high concentration of alloisoleucine, which is characteristic of maple syrup urine disease. Bob's parents were really concerned about their son's condition, and they asked the doctor for further clarification. So Dr. X referred them to Biochem 3D03 students for their expertise in metabolism. Maple syrup urine disease is an autosomal recessive disorder resulting from a deficiency in the branched-chain alpha-keto acid dehydrogenase complex enzyme, which we will refer to as the BCKD enzyme. The enzyme is made up of 3 subunits. The E1 subunit, or the branched-chain keto acid carboxylase, consists of 2 alpha and 2 beta subunits. Next, the E3 subunit, or the dihydrolipoamide dehydrogenase. And lastly, the E2 subunit, also known as dihydrolipoamide acetyltransferase. Along with these subunits, the enzyme requires 5 cofactors: thymine pyrophosphate, FAD, NAD+, lipoate, and coenzyme A. The BCKD enzyme is responsible for metabolism of branched-chain amino acids. These include valine, leucine, and isoleucine. These amino acids are essential in that they cannot be produced in the body and they have to be taken up from an exogenous source. Metabolizing these amino acids allows for the formation of neurotransmitters, signaling molecules, and anaplerosis. The branched-chain amino acids, or BCAA, are metabolized in the mitochondria of a variety of tissues, including the liver, adipose tissues, and largely in skeletal muscles. They undergo the reversible transamination reaction catalyzed by the branched-chain aminotransferase enzyme, or BCAT, to produce branched-chain alpha-keto acids, or BCKA. These BCKA then undergo an irreversible oxidative decarboxylation to become acyl-CoA ester forms and reduce NAD+ in the process, which is catalyzed by the BCKD complex. A series of steps can then convert the acyl-CoA esters into either succinyl-CoA, acetyl-CoA, or acetoacetate, depending on the specific amino acid. These products can then feed into the TCA cycle, or citric acid cycle, and then be used for oxidative respiration. This step performed by the BCKD is rate limiting and thus subjective to tight regulation. It commits the BCAA to disposal by 3 separate pathways, so let's focus on this portion of the pathway. The BCKD enzyme is covalently regulated based on plasma BCAA levels. At low BCAA levels, the E1 alpha subunit is phosphorylated by BCKD kinase, rendering it an inactive phosphorylated form of the complex. At high levels of BCAA, the E1 alpha subunit is dephosphorylated by BCKD phosphatase, activating the enzyme. The active BCKD may be allosterically inhibited by NADH and the acyl-CoA esters, and its kinase may be inhibited by the BCKAs, leading to inactivation of the enzyme. There is also long-term regulation, where on a low-protein diet, expression of BCKD is downregulated, and vice versa on a high-protein diet. The problem in MSUD lies in deficiencies of the BCKD enzyme or the BCKD phosphatase, preventing regulation. This results in the accumulation of branched-chain keto acids, along with the accumulation of the branched-chain amino acids themselves. So let's see how this accumulation of BCKAs and BCAAs might affect Bob's well-being and the implications that it has on cellular respiration. So an accumulation of the branched-chain amino acids and their keto acids halts aerobic metabolism, and it's been hypothesized that the way that aerobic metabolism is inhibited is through an inhibition of complex 1 of the electron transport chain, which inhibits the citric acid cycle, upregulates glycolysis, increases pyruvate levels, and stimulates anaerobic metabolism, explaining Bob's symptoms of metabolic acidosis. When everything is going well, the brain might use ketone bodies or glucose for energy. Ketone bodies specifically exit the liver from where they're synthesized and cross the blood-brain barrier through what's known as a monocarboxylate transporter, or an MCT. BCKAs, however, are also monocarboxylates, just like pyruvate, lactate, and ketone bodies, and may compete with these molecules and prevent their availability to the central nervous system. The lack of ketone body entry to the brain might be responsible for the neurodegenerative symptoms of MSUD that we might expect to see develop further in Bob's life. MSUD can also cause serious cardiac complications. While the brain relies on glucose and ketone bodies, cardiac muscle rely on pyruvate and fatty acids for energy. Once accumulated, BCAAs and BCKAs will inhibit pyruvate and fatty acid transport and utilization. Because cardiac tissue has a high demand for these molecules as the main source of energy, elevated BCAA and BCKA levels lead to an altered homeostasis in the heart, causing contractile dysfunction and accelerated heart failure. Now that we know about Bob and his maple syrup urine disease, let's talk about a possible treatment plan based on current and ongoing research. Typically, upon diagnosis of MSUD, the first and foremost method of action is to restrict dietary intake of the essential branched amino acids. Other treatment options include thiamine supplements or increased doses of thiamine, a cofactor of the BCKD enzyme that may be taken in the form of vitamin B1. By making a cofactor more available, it promotes residual enzyme functionality. Furthermore, insulin infusions to promote anabolism of protein rather than catabolism can help avoid the pathway altogether. Also, glucose infusions may be administered to promote energy availability to the heart and brain. Current research is investigating the possibility of retrovirus-mediated gene transfer of the E1 alpha subunit and other subunits of the dehydrogenase complex to help restore wild-type activity of BCKD. We would advise that Bob uses the 3 established treatment methods in combination for a synergistic effect that is greater than any treatment alone. And so, we would hope that Dr. X administers thiamine, insulin, and glucose infusions. Though no treatment for MSUD has been perfect in reversing its detrimental symptoms, we, on behalf of Biochem 3D03, hypothesize a potential novel treatment for MSUD. Let's remember when we talked about MCT, a transporter used to carry monocarboxylates such as pyruvate, lactate, and ketone bodies from one tissue to another. Since BCKAs and BCAAs are also monocarboxylates themselves, it's been suggested that they can compete with these molecules and prevent their transport. Studies have shown that if you put a mouse on a low carbohydrate diet relative to a high fat diet, it'll reduce the availability of glucose and consequently increase the ketone body synthesis to fuel the brain. The study showed that this increase in ketone body synthesis causes an upregulation in the MCT expression required for transport. Taking advantage of this research, we proposed that putting Bob on a high-fat diet, along with restriction of BCAA intake, will not only decrease plasma BCKA in competition with MCTs, but will also create additional MCTs to allow for uptake in ketone bodies, pyruvate, and lactate molecules, thus minimizing metabolic disturbances. Luckily, Bob was diagnosed at an early stage of the disease, so we were able to implement a strict diet and combined treatment plan immediately after diagnosis. Since we're starting him on this diet early on, we can prevent accumulation of keto acids and amino acids that would lead to neurodegeneration. This will help reduce the risk of physical damage, including potential brain damage and heart failure. Through our understanding of the disease, we also hope that we can help Bob achieve an improved quality of life. Future research will also help us elucidate key findings in the pathways affected by MSUD. With this deeper understanding, not only can treatments be improved, but a potential cure may be in sight.